Thank you very much, Mr. Kelberg. Now we'll begin with questions and comments, and let me begin. Let me begin by asking all of our distinguished panelists a very simple question. In the United States today, we are the only nation in the industrialized world that does not guarantee people health care as a right. And we still have, well, the numbers have gone down since the Affordable Care Act, but we still have many, many millions of people who have no health insurance at all. Others have high co-payments or deductibles. So let me ask all of the panelists a very simple question. Should health care be a right of all people, regardless of income? Yes, no, maybe. Ms. Cheng? Should health care be a right of all people?
I think it should. I think it should because it is a sign and expression of a civil society.
Okay, I'm going to ask for brief answers. Dr. Ye?
Yeah, access to health care, regardless of their job, their income, is in an inalienable right in our Constitution.
Okay, Ms. Pipes?
No. We're entitled to life, liberty, and the pursuit of happiness. How do you determine which right is worth more? Do we have a right to housing, a right to food, a right to health care? How do you measure which is the appropriate level? So, no.
Okay, thank you. Dr. Martin?
Yes, access to health care is a human right, and I know that the vast majority of Canadians in poll after poll feel the same way.
Mr. Kelberg?
Yes, I believe that access to health care should be a right.
Dr. Hogberg?
Yes, I think it should be a right in the classical liberal notion of rights, that government should not interfere, Congress should make no law, and so forth. So yes, everyone should have the right to health care in that sense.
Dr. Rodin?
We have a right for health care in the United States for emergency care. I believe that should be extended to primary care as well.
Okay, let me stay on that point, maybe get to Dr. Hoberg. You indicated that you thought health care should be a right, but government should not be involved in that process. Does that suggest that you would do away with the government-run Medicare program?
It's a moot point.
No, it's not.
It's a very moot point because seniors vote at very, very high rates, and we're not getting rid of Medicare. It's an academic
But I'm
question.
asking you as an academic. You're not, seniors do want it, you're right, it's a popular program. Mm-hmm. But if you say government should not be involved in health care, and Medicare is a government health care program, mm-hmm. in your judgment, in the best of all your possible worlds, should we vote to get rid of Medicare? Some people think we should. What do you think?
I think it's a moot point. It's here to stay.
Well, I think you didn't answer my question. Ms. Pipes, I would like to ask you that question.
I believe that we are not going to get rid of Medicare. Medicare is a program for our seniors. I think we do have severe problems. The Medicare trustees have said that Medicare will be bankrupt by 2024, just at a cost of over $1 trillion.
I just wanted to ask you a simple question.
It should be
Medicare is a government-run program.
Right.
As Dr. Hoberg indicated, I think it's a popular program. We could disagree. We have disagreements. My question is, should, in your judgment, we abolish this government-run Medicare program?
Not entirely. Medicare should be there for those people who truly need it. The problem is...
Truly need it, but not as it is right now.
Because a lot of people who are wealthy can afford care, and they're
not a lot of people
putting a lot of
are
cost
wealthy.
pressure
Right.
on the system. Paul Ryan, Congressman Ryan, I think has some very good ideas.
Right,
on
and he would
premium support,
transform
changing the
Medicare
age.
into a voucher program. Dr. Rodman, let me ask you a question. Despite the fact that our health care outcomes are not particularly good in terms of infant mortality, in terms of life expectancy, the United States ends up spending almost twice as much money per person on health care as any other nation. Why is that? And I'm going to give you, and we'll give Senator Burr additional time as well. Dr. Rodman, why is that? Put your mic on.
We spend more, Senator Sanders, for several reasons. First, our prices are higher than all other wealthy OECD nations.
All right, if a woman has a birth in this country compared to France, how much more does it cost? Or give me some examples.
It can cost different prices here depending on who insures you. It can range from the $5,000 to $27,000. The figures are in the excellent paper by Mei Chen from OECD for all to see. So price is one very, very important phenomenon. Prices of drugs, prices of...
How do drug prices compare in the United States compared to other countries?
In the aggregate, they are much higher. Much
Why
higher.
is that?
Why is that?
Yeah.
Because we have no price control. Because
So if I need a cancer drug in the United States, why is it much more expensive here than it is in Canada or in France?
in Canada and in France, you have regulated prices for these drugs, and people have access to them. In France,
That interferes with the free market system. Is that a good idea?
of course, it's a good idea. The free market system doesn't exist anywhere in healthcare. I challenge anyone to give me one example of a free market system that is operational and works. It's a fine idea in theory, but I challenge anyone to give me one concrete example. All the evidence suggests that it does not work.
Okay, Senator Burr.
Dr. Martin, in your testimony, you note that Canadian doctors exiting the public system for the private sector has had the effect of increasing waiting lists for patients seeking public health care. Why are doctors exiting the public system in Canada?
Thank you for your question, Senator. If I didn't express myself in a way that make myself understood, I apologize. There are no doctors exiting the public system in Canada, and in fact, we see a net influx of physicians from the United States into the Canadian system over the last number of years. What I did say was that the solution to the wait time challenge that we have in Canada, which we do have a difficult time with waits for elective medical procedures, does not lie in moving away from our single-payer system towards a multi-payer system. And that's borne out by the experience of Australia. So Australia used to have a single-tier system, and in the 1990s moved to a multiple payer system where private insurance was permitted. And a very well-known study by Duckett et al. Tracked what took place in terms of wait times in Australia as the multi-payer system was put in place. And what they found was, in those areas of Australia where private insurance was being taken up and utilized, waits in the public system became longer.
What do you say to an elected official who goes to Florida and not the Canadian system to have a heart valve replaced?
It's actually interesting because, in fact, the people who are the pioneers of that particular surgery, which Premier Williams had, and had the best health outcomes in the world for that surgery, are in Toronto at the Peter Monk Cardiac Centre, just down the street from where I work. So what I say is that sometimes people have a perception, and I believe that actually this is fueled in part by media discourse, that going to where you pay more for something, that necessarily makes it better, but it's not actually borne out by the evidence on outcomes from that cardiac surgery or any other.
One would believe the American people prefer their system because they know consciously they pay more. No, I think it's because they judge quality and they judge innovation. Ms. Pipes, in your testimony, you noted that more than 42,000 Canadians come to the United States each year for health care. Why is that?
Because they find that they're on a waiting list in Canada for too long a period, and they feel that their health is at stake. So a lot of people in Canada come to the U.S. for MRIs, CT scans. There are many examples in the media of people like Brian McCreath, who came to the U.S. because he was told by his primary care doctor that he might have a brain tumor, but the wait for an MRI was very long. He spent the $1,000, came to the U.S., paid out of pocket. You will see advertisements in Canadian newspapers for MRIs, for neurosurgery.
It's a pretty fertile ground to market in.
Right.
Dr. Martin, in your testimony, you state that the focus should be on reducing waiting times in a way that's equitable for all. What length of time do you consider to be equitable when waiting for care?
Well, in fact, the Wait Time Alliance in Canada, sir, has established benchmarks across a variety of different diagnoses for what's a reasonable period to wait. And what we've found is that actually working within the single-payer system, we can reorganize things. You know, I waited more than 30 minutes at the security line to get into this building today. And when I arrived in the lobby, I noticed across the hall that there was a second entry point with no lineup whatsoever. Sometimes it's not actually about the amount of resources that you have, but rather about how you organize incentivize people in order to use your queues most effectively. And that's what we're working to do, because we believe that when you try to address wait times, you should do it in a way that benefits everyone, not just people who can afford to pay.
On average, how many Canadian patients on a waiting list die each year? Do you know?
I don't, sir, but I know that there are 45,000 in America who die waiting because they don't have insurance at all.
Well, let me go back to Dr. Rodwin's statement. The American system has access to health care for everybody. It's called the emergency room. Now, we don't admit that clearly because we're lobbying for a particular angle. But every American can access health care. They can access primary care. And Dr. Rodwin, I would agree with you that we ought to make sure that there's a medical home for practically everybody we can place. We don't do it in Medicaid. We should. States should adopt it because primary care is an absolute necessity to wellness. But, Mr. Kjellberg, how many Danish citizens have supplemental health insurance policies, and why has that number been increasing in recent years?
About half the population got co-payment insurance, and that have increased dramatically over the last year because your family were included, so children were included, and that brought up the numbers quite significantly. But the number of policyholders haven't really changed much.
But half the population has supplemental insurance.
Co-payment insurance. And then many people in the labor market also, as part of a benefit package, are offered health insurance so you can have faster access to elective care.
So they can actually buy their way to faster access.
Oh, you can buy that. There are private hospitals. You can buy any hospital services in Denmark.
So they have options. They have choices.
They have choice, yeah.
Dr. Rodwin, in your testimony, you note that Parliament sets healthcare expenditure targets each year. If a hospital or a physician exceeds their target expenditure by billing for higher than projected volume of services, prices are negotiated downward for the following year. Beyond volume or utilization of services, are there quality metrics that the French use to determine reimbursements for physicians or other providers in order to incentivize quality care for patients? For example, measuring health outcomes to ensure patients are receiving quality care.
Well, this is a science that's not well developed neither in our country nor in France, but they are working on this very question, which is very timely. Right now. That is, the negotiations focus certainly on volume, but now there's a program called IFAC, which will remunerate physicians. Well, that's actually already in place if they follow certain standards of preventive care.
But they're penalized if they bill at a higher rate one year. They're penalized in the next year by a reduction in the reimbursement.
Every year, sir, there's a negotiation to set these rates, and if the volume goes up, then the following year, the prices, that's the practice, it's the volume health performance standard.
Thank you, Doctor.
Yes, it's
Thank you, Mr. Chairman.
Budget target.
Senator Nancy.
Thank you, Mr. Chairman, and I want to thank the distinguished panel for all of the information that they've provided. It's a session that Senator Kennedy and I held several years ago, but first of all, I want to thank Ms. Pipes for being here. She wrote a book in 2010 that predicted what was going to happen with our health care system as it is now. And then more recently, she's written something called The Cure for Obamacare, and it's not even copyrighted, but it's an outstanding book on what we could do to repair the damage that's been done on our present system. And I thank you for your effort on that and hope I can get a few more people to read them. I mentioned Senator Kennedy and I, when I was the chairman and he was the ranking member, we went to a system called a roundtable, and this is very similar, except that at a roundtable we had, again, 8 to 10 people, and they were all practitioners of some sort in the healthcare area rather than people who were studying the healthcare system. And he and I would come up with the questions for the panel, as well as total agreement on who should serve on it, as opposed to the way we do panels now, which is the chairman gets to pick everybody, 4/5 of every panel, and the ranking member gets to pick another 1 or 2, and then we all come and beat up on the witnesses. So at a round table, the senators really didn't speak much, but one of the questions we asked is, will universal single-pay health care work in America? And the first person was an engineer for hospitals, and he wasn't sure. But the other practitioners all said, America won't settle for universal single-pay health care. At the end of that hearing, that roundtable, Senator Kennedy came to me and he said, I guess we better take a look at some of the things you've suggested, like small business health plans and being able to sell across state lines and things like that. And I think one of the things that this panel points out, most of you are talking about countries whose population is and size in some cases is relative to our states, each state. And in the United States, each state has health care plans, and they do it differently. And as the chairman mentioned, some of them have good ideas, and those spread to others. But what will work in Canada with a smaller population, or Denmark with a smaller population, or France with a smaller population, might not work in the United States, especially under the form of government that we've got. I'm pretty sure that the Affordable Health Care initiative was designed to fail. That was predicted by Senator Graham about 15 years ago, and he thought that they would come up with a system that would fail, and then we could go to universal single-pay health care. I think that would have worked, except for one thing. The debacle with the design of the exchange reminded people in America what happens when our federal government tries to handle everything for this vast United States with one plan. And of course, I'm on the Homeland Security Committee too, and we're trying to work with another one of those government agencies that's called the Post Office. And that's another example that people use of what might happen if we went to universal single-pay health care. I've been to some countries that have a lot of population, like India, and they're very proud of their system. I asked how they took care of that vast of a population, and they said, well, our doctors see 200 patients a day. I don't think our doctors see 200 patients a day and wouldn't take that quick of action. The question of Medicare that was asked earlier, if people were given another option, I think they'd go with another option. Too many people in America right now that are seniors at least know somebody that tried to see a doctor, and the doctor said, I'm not seeing any Medicare patients. So Medicare is not the best example of how to get health care in America. And I've almost used up my time without asking a question. I'm the accountant on the panel. In fact, I'm one of 3 accountants in the United States Senate. And so the questions that I have are really kind of technical and get down to some of the costs. And so I'll submit those in writing and would appreciate it if you'd answer the questions. Thank you. Thank you, Mr. Chairman.
Thank you very much, Senator Enzi. Senator Roberts.
Well, I too want to thank the panel and thank you, Mr. Chairman, for holding this hearing. It seems to me that the entire question here has been summed up by the chairman. Does the government, if we have a government guarantee of health care as a right, he posed that question. And then with questions, Senator Enzi and Senator Burr have pointed out, or is it a right to a waiting list? Actually, I think that is the statement by Ms. Pipes. And Ms. Pipes, my deep regrets for the loss of your mother. How long did she have to wait?
She went to her primary care doctor, her general practitioner, we call him, in June, and she was admitted to Vancouver General Hospital, which is one of the largest hospitals in Canada, in late November.
Late November. And then you lost her after 2 weeks. Did you say that you could get a hip replacement for a dog in a week, but you couldn't get a hip replacement for an individual for X number of
2
weeks?
years. Yes, the wait for orthopedics is one of the longest waits in Canada, and my friend Dr. Brian Day, who's an orthopedic surgeon in Vancouver, made that statement to the New York Times. Dr. Day, who runs the Cambie Clinic, is being sued by the British Columbia government for operating a clinic which is considered illegal in British Columbia. The interesting thing is, he told me the other day, the government keeps postponing the case, and I think it's because his practice is so busy with people getting hip replacements, knee replacements, that they're afraid of the backlash that will happen because of that.
I have legislation that I call the Four Rationers Repeal Bill. I'm not going to get into the four rationing boards, IPAB, CER, et cetera, to address some of my concerns about the government controls and where we are with the Affordable Health Care Act. I'm trying to get ahead of that curve. By the way, I don't know, Dr. Martin, does Prime Minister Harper, does he change the rules and delay implementation of the system every week like we see going on with the Affordable Health Care Act?
I'm not sure that you want me to answer that question, sir. I don't completely understand what you're saying. But
I'm saying that the Prime Minister of Canada, I don't think, changes the National Health Care Act that we have in place, which I think is basically a first step toward single payer, and I think that was the intent of it. The President of the United States has changed the health care. About every Friday we have what we call a regulation dump, okay? A consortium of unions indicated that they would like a big change in the Affordable Health Care Act. He's going to have a carve-out for them. On the other side of the fence, 27 members of the Finance Committee, some on this committee, wrote to Marilyn Tavender, the head of the Centers of Medicare and Medicaid Services, to say, whoa, don't change the Medicare D program that we have in this country, a very popular program under budget, used by a great number of our senior citizens. And if we hadn't written the letter and if there hadn't been a real backlash from the people to save Medicare Part D, it wouldn't have happened. So we're just sort of writing this thing as we go along, except the President doesn't come to us and ask us to help him do that with each individual change. I'm just wondering, with the problems you have up in Canada, who makes the change, if in fact there needs to be a change?
Well, I suppose there's the answer to your question comes in two parts. The first is in acknowledgement, I think, of what Senator Enzi was saying earlier on, which is that like the United States, Canada is a huge country, and our health insurance is actually not provided at the national or federal level. It's provided at the provincial level, or the equivalent of your states. And so the notion that something can begin in one subnational jurisdiction and then spread is in fact exactly how we came to have 13 separate single-payer systems in the 13 provinces and territories of Canada. And so the first part of the answer to your question is no, we don't see that kind of those kinds of changes being made to healthcare legislation at the national level. But the second part of the answer to your question is that it is widely known in Canada that the public commitment to our single-payer Medicare system is so strong that for a Prime Minister of any political stripe to try to alter that and undermine it in any way would be political suicide.
I got your message. Dr. Hoberg, you mentioned the fact we ought to keep the politicians out, and we've just had two changes, Medicare Part D and then also a carve-out for the unions. Is that an example of what we're talking about? And 33 other changes, by the way, and that's the last count that I have.
Well, I mean, they're very good examples of groups that have political clout can keep changes from happening that they don't want to see. Unions and seniors certainly have plenty of clout up here on Capitol Hill. And if would you mind if I would just take a second to talk about some of the outcome measures here?
Well, I'm already over time, 23 seconds. I'll ask the permission of the chairman if that would be possible.
Take another 30 seconds.
All right, thank you, sir. You got 30 seconds.
Yeah, first of all, with regard to life expectancy and infant mortality, using those as measures of to tell you something about a healthcare system is a bit like using batting average and on-base percentage to tell you something about football. Life expectancy and infant mortality, there are so many factors that go into those outcomes that are not related to the healthcare system, that the healthcare system has no control over, that they are really not good measures for telling you the quality of a healthcare system. One other problem is that many of these measures are not measured the same from country to country, infant mortality being the...
Well, I thank you for that. The chairman's already hit the gavel. My main question is access to care and denial of that care, and what other alternative a person has to the single-payer system.
Okay, Senator, we're going to have another round of questions. This is a great panel. I think they're good questions. But let me pick up on a point. That's my turn now. Pick up on a point that Dr. Martin raised, because I was going to ask the same question. I live 1 hour away from the Canadian border. Canadians watch American television. Canadians are very familiar with our political system, probably know more about politics in America than most Americans know. Is your Prime Minister a socialist?
No, sir, our Prime Minister is quite conservative. He's the leader.
Conservative?
Yes, indeed.
So obviously, as a conservative, he wants to implement the American healthcare system that the Canadians are very aware of. I gather that was probably the first thing he did when he took power. Is that right?
Not exactly.
Why not?
Support for single-payer Medicare in Canada goes across all political stripes. Quite famously, we had the leader of the most right-wing party in a Canadian federal debate on television hold up a sign in the middle of the debate on which he'd written in marker, "No two-tier," as a means of trying to reassure the Canadian public that if elected, he would not dismantle the
So in other words, you have a nation bordering on the United States, two nations that are probably as close together in so many respects as any two nations in the world, a conservative prime minister, and yet there is no effort to move to an American healthcare system. I would say to my colleagues, there's not a better example of maybe how people feel about two systems. They know the American system. They have a conservative prime minister. They can move in our direction, but for whatever reason, and I think sensible reasons, they understand that a system that guarantees health care to all of their people in a cost-effective way is the way that they want to stay. Ms. Pipes, let me ask you that question. Why do the Canadians not come to the American health care system?
Well, as I mentioned in my testimony, about 42,000 Canadians every year come to the U.S. and pay out of pocket for assistance.
That wasn't my question.
No, I just made that. I want to make that point first. Second, the Canadian government and the provinces who administer the Canadian healthcare system, this started in 1974. A lot of people in Canada have no idea of an alternative system.
Oh, my goodness. They live an hour away from me in Burlington, Vermont. They watch American television. They read American newspapers. They have no idea of what goes on in the United States of America. That is a little bit hard for me to believe.
I would say that Canadian people are very, very nice people. They're not impatient like Americans. My mother said to me, I hope you're not becoming an impatient American. I am an impatient American. Americans do not want to wait. Canadians are very nice.
Well,
the doctor says, and then the second...
Ms. Pipes, I have a limited time.
Yes.
I think the answer is pretty clear. The Canadians have seen the American system. They prefer their own. Now, I want to say a word about access, because and waiting lists. Senator Roberts raised that issue, and Senator Byrd did. I want to focus on that picture over there. I know it's hard to believe, and I mean this quite seriously. This is the United States of America. This is not a third world developing country. This is a town called Wise, Virginia, and I don't mean to pick on Virginia, because I think the same story can be told all over America. So when we talk about access, what we're looking at here is that a number of times a year, people, working class people, who have no health insurance at all, are given free health care, episodic care. Volunteer doctors very kindly come, and in a day, thousands of people line up because this is the health care they get. This takes place in a field in Wise, Virginia. I think it's a stadium in Los Angeles where something similar takes place. Now, if this is the kind of health care that we are proud of in the United States of America, well, some of us have some strong disagreements about that. Dr. Rodwin, I want to get back to another point, which to me is very important. It is, and I'd like Dr. Martin to comment on this as well, and maybe Dr. Ye and Ms. Cheng. To get good health care, you need medicine very often. If I go into a French hospital, I leave the hospital and I'm sick, how much does my medicine cost?
Under French national health insurance, there's very high levels of pharmaceutical coverage.
Meaning what? My medicine is free or virtually free?
Virtually free, 90%, 80%, 70%.
Right, Dr. Martin?
Those prescription drugs that are cut because they're ineffective.
Okay. Dr. Martin?
So interestingly, this is an area where we made a mistake in the design of our single-payer program in Canada. At the time that Canadian Medicare was designed in the 1950s and 60s, medication was not a really big part of the way that we treated disease, and medicines were left out of coverage. So the single-payer program in Canada does not include medications, and as a result, 1 in 10 Canadians today fails to fill a prescription or take their medicine as prescribed because of concerns about cost.
Thank you. Mr. Kjellberg, what about prescription drugs in Denmark?
All hospital use at hospital are free of charge, and if prescription drugs are needed, you have a maximum co-payment a year about $600.
Okay. Dr. Ye, in Taiwan, how much do prescription drugs cost?
It is covered by the NHI, but patient had to pay some copayment up to the ceiling of about $10 US.
Up to $10 US?
Up to 10. And each year add up to be the ceiling, including hospitalization, the ceiling will be $1,000 US.
Ms. Chen, what's your view on prescription drugs?
The prescription drug use in the United States, in fact, is low compared to total health spending. Relatively speaking, in Europe as well as in Taiwan, the percent of money spent on drugs in terms of total health spending is a much higher percentage. Example, in the French system is roughly 25%. In Taiwan, 25% of total health spending is on drugs. So they have much greater access to drugs. That's number one. Number two, the reason why the drug price...
I apologize. My time has gone over. Senator Murphy has joined us, and Senator Murphy, do you have some questions you wanted to ask?
Yeah, thank you very much, Mr. Chairman. Thank you for this hearing, and to all of the witnesses. I'm sorry I had to step out for a few moments. I guess I just sort of had one broad question for the panel, because I think it's come up in some of the testimony, especially I think from Ms. Pipes and Dr. Martin. And I'm always fascinated by this intersection between convenience and quality. And to the extent to which metrics like wait times often don't automatically translate into differences in outcomes. Often they do. I mean, there's some services in which if you don't get it right away, it's going to have a pretty severe consequence on your health and on the amount of money you're going to spend later on. But, you know, there are parts of this country, for instance, that have enormous convenience, that you can't drive more than a couple miles outside your door and without finding an MRI machine or a dialysis center. And, you know, there's healthcare all around you. And yet that doesn't seem to be adding to quality. That seems to be adding to convenience. Similarly, I hear all of the stories from Canada that Ms. Pipes talked about in terms of wait times, and yet when we sort of look at all the underlying data, it tells us that, you know, in the end, on a lot of the diseases where you have wait times that might cause you to question the system, the outcomes in Canada are fundamentally better than they are in the United States, from heart disease to cancer. So that's not to say that we shouldn't sort of look at issues of convenience and issues of wait times and your proximity, either spatially or temporally, to services. But I wanted to kind of, I mean, specifically kind of asking Dr. Martin and Ms. Pipes to talk about this, but maybe asking others in the panel who have thoughts about this with your experiences, to talk about how in other countries where there may be less easy access to health services, not as much health care as we have in the United States, we have tons of it, as to whether that actually has a true relation all the time to the outcomes that we get. Dr. Martin, happy to have you start.
Thank you. It's a really thoughtful question. And I guess I might reframe it slightly by saying that what you refer to as convenience, I would refer to as patient experience. And so when we talk about quality in healthcare, the so-called triple aim, coined by Don Berwick of the IHI here, the notion of quality having three dimensions. One is population health outcomes, on which single-payer countries like Canada fare, in fact, quite well. Another aspect of the triple aim is cost per capita, and the third is patient experience. And of course, patient experience is important. And so, I said that I wasn't here to be an apologist for every single thing about the Canadian healthcare system. We're working very hard on reducing wait times for elective surgeries because we believe that patient experience matters. But you're right that our outcomes are very good. And I think it's critically important for the committee to understand that single payer does not equal wait times. We heard our colleagues from Taiwan tell us quite clearly that they have a single payer system with virtually no wait times, with 99.6% coverage of the entire population. And so, of course, we should consider all aspects of the AAA when we talk about quality, but we should not we should avoid oversimplifying the message and equating a single payer model with wait times. That simply is not the case.
Madam Justice Marie Deschamps, who retired from the Canadian Supreme Court in 2012, in that hearing in 2005 said the idea of a single-payer healthcare system without waiting lists is an oxymoron. So I just want to make that point that and the Canadian Supreme Court is not a conservative court by any stretch of the imagination. I think, you have
But do you dispute the characterization of the Taiwan system?
Well, the United States, I think, as Senator Burr said, we have 315 million people here. We have such a diverse, we do not have a homogenous society, which is much more typical in many other countries around the world. I did want to make a point about life expectancy, and the WHO, the World Health Organization, often says the United States ranks 37th out of 190 countries. Well, as Professor Stephen Wolfe, who was the lead author in the Institute of Medicine study, which, was really based on life expectancy and infant mortality rates, he said life expectancy and other noted health outcomes are determined by much more than health care. And here in America, when you look at our lifestyle choices, we have a huge obesity problem. We have homicides and car accident deaths at a much higher per capita rate than any country in the world. So when you look at the numbers for 5-year survival rates on cancer, based on the work done by Lancet Oncology, the United States ranks #1 in the world on 13 of the 16 most popular cancers. So you have to be careful when you're doing statistics that you're comparing apples to apples.
Well, great. Thank you very much. My time has expired, Mr. Chairman.
Senator Burr.
Thank you, Mr. Chairman. Let me say before I ask the second round of questions, there's been a lot of reference to Medicare and single-payer system. Let me just remind everybody, in Medicare, for a working lifetime, I pay into a system to finance part. There is a government share. When I become a senior and I go and get Part B coverage, which is the physician side, I pay a premium for that. When I go to get drug coverage, I pay a premium for that. You can't look at Medicare and say this is like the single-payer system in Taiwan where the government picks up the entire tab. Now, health care is not free. We all know that. It comes out of general taxes. But there's a difference for seniors in America that they are personally invested into a system, and they even have choices. They can choose a Medicare Advantage, which is a private sector coverage. At least they could before Obamacare, and now that's getting knocked out. And they can choose as a senior to buy Medigap insurance, so they can buy their way out of skin in the game. The one thing that I heard is that everybody, except for possibly Taiwan, has some degree of copay. France does, Canada doesn't, but they do as it relates to drugs because they're on their own for drugs. And what I want to talk about is drugs because, Ms. Chen, Dr. Yu, our friend from Taiwan, said in his testimony that patients in Taiwan can experience delays in coverage for new drugs and new technologies from 2 to 5 years from adoption of the United States in that. And Ms. Chen, you touched on prescription drug prices in your testimony. Almost all countries enjoy the benefits of America's medical research and development, but developed countries don't pay their fair share for the immense expense involved in the development of innovative life-saving therapies. These countries are free riders on the United States by enacting price controls on drugs and devices. How would sharing more of the financial burden that comes with research development of life-saving drugs and devices affect comparison between the United States and the countries we're discussing today? That's to you, Ms. Chen.
Thank you for this question. First of all, yes, United States does fund a whole lot of R&D in pharmaceutical and other device innovations. But in so doing, we are also helping to make the American healthcare system that much more expensive. In fact, so expensive that we're pricing people out of the healthcare altogether. So United States is you know, we're so in terms of R&D in single-payer systems, I think it is the governments of these systems can set aside specific R&D funds to help with R&D for innovations.
Ms. Chen, in the U.S. system, when we shifted from exclusively doing bypass surgery for heart blockage,
right.
And we went to catheterization because innovation allowed us, or technology allowed us to do catheterization. Do you consider that to be a cost savings to the United States or the expense of a new innovation?
If it is done on the right patients at the right time, yes, it is a cost-saving innovation and application of that innovation. However, I think with United States healthcare, there's a very serious issue which has not been addressed, which is overuse of services. We have here in my testimony, there's
But in that the risk of letting the American people choose health care and having a marketplace versus having government dictate what, where, when, and how much?
It's not a matter of letting people decide in the marketplace where to go or what to choose, what to have.
We overprescribe grossly pharmaceuticals in the United States. Why? Because the American patient has the right to go in and ask their doctor, and because of our liability exposure, the doctor feels compelled to write the script in the United States. And I would tell you that's a lot of the health care, a lot of the drug costs. Let me just move.
May I just say
Yes,
this? In a Institute of Medicine book, in fact, I brought it, it says that this overuse of everything, services, devices, drugs, it causes waste in the American health system. According to this Institute of Medicine book, about 1/3 of U.S. healthcare is waste, and $750 billion a year. And of that, unnecessary services accounts for $210 billion of the $750 billion.
I wouldn't disagree with the conclusion of that. I have one last question, Mr. Chairman, and it's to Dr. Hogberg. In contrast to what I've just talked about with Ms. Chen, price controls overseas don't reward innovation. If the United States were to follow the price control model, what would happen to patients' access to innovative treatments here in America as well as overseas?
In the long run, you would see less access to new innovative drugs. It'd be that simple.
So if in fact we eliminated innovation, in many cases that innovation which takes somebody out of a hospital setting, puts them in an outpatient facility, they're treated, they no longer have the risk of infection because of inpatient, they no longer have the days in the hospital. That's not only been beneficial to the cost in healthcare, it's actually beneficial to the quality of the outcome.
Well, sure. Frank Lichtenberg's looked at this extensively, and he's estimated that for about every dollar we put into pharmaceuticals, you save well over $3 in hospital costs by avoiding hospitalizations. The price controls can have one of two impacts. If you have price control that's lower than the market price, you'll see a shortage. If it's above the market price, you'll see a sorry, I'm losing my train of thought here. You'll see a surplus, and that's kind of what you're going to end up with, a system of price controls.
I thank you. I thank our witnesses. I would ask the chairman for unanimous consent to allow us to submit questions to all the witnesses for the purposes of the record.
Absolutely. And this has been, let me thank all of you for being here. And I want to apologize. I would like to stay for another round of questioning, but we have votes that are taking place right now. So I think this has been a very thoughtful and vigorous discussion, and I appreciate all of you very much for being here. Thank you. This hearing is adjourned.